Into the server. Hold on. Right. Hello. Good evening, everybody. This is Mika Janhunen here again for the Sports Chiropractic Chat Show. And this evening on podcast episode 3, we have the distinct honor and pleasure of hosting Simon King, who has a long and illustrious career in sports chiropractic and treating athletes of all sorts of walks and across the genre, and a man with great knowledge when it comes to, fun enough, neurology, which is a bit of a topic for us today. Now, Simon, I'm not sure if you recall, but we have indeed met a long time ago, very in the history of time. I recall when I was still a student back in AECC. So this must have been back in, I would say, 2006, perhaps. And you came to deliver a little bit of should we call it a workshop or a lecture? It wasn't exactly a lecture. It's more like an interactive workshop that you did for some of our students there. And I was in the audience there and feeling a bit apprehensive, purely because I recall one of the tutors in AECC in Bournemouth, we'll let them remain anonymous at this point, but they said that Simon is a bit of a maverick when it comes to this stuff. He's the rock star of chiropractors, and he's the guy who we send patients we don't know what to do with. And so that basically cemented your reputation in my mind at the time, and a lot of my fellow students. And obviously, as you then rocked up and delivered your workshop and presentation, there was a distinct electricity in the air, I recall, and we were all desperate to find out more about what you did and what made you actually that kind of rock star, which was definitely didn't disappoint there. So there was all sorts of things that happened, and we couldn't understand why. Let's put it that way.
Okay.
I'm sure you have had this kind of reaction before, when it comes to patients as well as workshops you deliver, where people it's almost like there's a magic ingredient that you can't quite put your finger on. Why does it actually work?
I love that Arthur C. Clarke quote, that any sufficiently advanced technology must seem like magic. It's something like that anyway. And I think, if you can get the neurology right, then it does seem like a sufficiently advanced technology, and often it does seem like magic, but it's not, of course. There's no magic involved. It's just understanding matter, understanding in my case, understanding Sherrington's reflexes. That's the key to my work, really, is understanding the reflexes that Sherrington published back in 1906, and are true in every vertebrate. They are universally true in every vertebrate. So there's no guesswork with those. They happen every time, all the time. And if you can learn to work with what is rather than what you suspect or what you want to be, then it does seem magical, really.
Oh, quite right. Absolutely. And I mean, obviously, us at the time, I think I must have been fifth year student, maybe fourth year. And our sort of appreciation, should we call it, of neurology and the finer points of neurology was quite clouded at the time. And, we were desperate to pass exams, which obviously is what school is there for, is to essentially stop us killing people and make sure we are, safe and competent practitioners as it goes, when it comes to the basics. But yeah, the stuff you covered in the workshop wasn't covered in our lectures at the time.
And it's not. And one of the biggest problems with, when you go and learn how to pass exams, you learn as much as you need to learn to get through the exams and get the answers right. But it doesn't really give you a clinical understanding. It can't do. And it took me 15 years to go back to the neurology textbooks and try to figure out how this stuff actually worked. And it was only going back to the textbooks, but with, my clinical background, that allowed me to sort of figure it out. So yeah, it's tough
absolutely.
for students.
No, absolutely. I agree. That's something that, of course, now I've been out since college now 12, 13 years. And it's that kind of time frame, I suppose, I'm starting to ask different questions of myself. I've been looking into doing things in a number of different ways, and trying to figure out what is my way, what makes sense to me, and how I can figure it out, and how does it apply to patients who are on my bench, or even on the pitch and whatnots. And I'm starting to connect the dots, let's call it that.
Yeah, sure. Yes.
And of course, that's something that then the patients loudly exclaim, wow, it's a miracle when you do connect the dots.
And doesn't that make you feel good? Because you can get lots of, but the trouble is, it's always those ones that you don't get right that you lose sleep over. And I'm privileged now that there's not too many of those. So I like the miracles. I like doing my job competently. That's what I like. I like to be competent. So.
Oh, absolutely. Well, it's like my grandpa always used to say, it's that feeling of a job well done.
Yes, exactly.
Where you give yourself a little bit of a, well done, lad, taste another one. There you go. And that's something that, gives me absolute and utmost satisfaction as well, when it's elementary, dear Watson, isn't it?
Yeah, that's right.
After all. Yeah. But yeah, no, oftentimes, I don't know. I mean, I see, you get this a lot, I'm sure, but I personally, I see a lot of patients who come from, they've done the rounds, they've been to see this person and that person, another person. And oftentimes the very basics have been missed, whether it comes to mechanics, whether it comes to neurology, whether it comes to a bit of nutrition, bit of exercise habits, whatnot. But oftentimes people don't look at the basics. Would you agree with that?
I'm not sure. I think most of the patients that I see, because a lot of my practice is sorting out other people's problems, so that, and they're usually the chiropractors that I've trained, so they're no slouches. But even the best run into, run out of capacity sometimes, and then they just need a little bit of help and guidance. And so I enjoy seeing other people's patients, and I usually only see them once. That's because I like to be able to get to the root of the problem quickly. That's really what I like to do.
No, absolutely. I think that's definitely best for you, and it's best for the patient, and best for the referring chiropractor as well, I reckon.
Sure.
But
I'd rather send them back to them to do all the maintenance stuff. I don't enjoy maintenance. I just like to fix people, really.
Yeah, you enjoy the challenge of figuring it out and then sorting it out, isn't it? No, that's brilliant.
Yeah.
No, absolutely great. So if you look at it from a slightly different perspective, what do you think is the problem with the chiropractic profession these days? What's the kind of thing that mostly gets missed?
Well, from my paradigm, it is muscle tone. So to me, muscle tone is the basis of everything. And I think people, when you talk about muscle tone, people think they know what it is, but often they don't fully understand it. So you have to, so can I give you my muscle tone outline?
Please do.
When I'm talking about muscle tone, I'm talking about the output of a motor neuron to the muscle, okay?
Yes.
And because we have resting muscle tone, that output from a motor neuron is not dependent on anything we do. So let's say we're totally at rest. Every motor neuron is still firing at 50 times a second, even when we're resting, to every muscle, right? Every muscle. And when we start to work that muscle at full contraction, that motor neuron is firing at 500 times a second. So that's what we're talking about when I talk about muscle tone. It's the inbuilt output from the motor neuron that is creating that muscle tone, even at rest, okay? So when you tell me that you're going to exercise to get more muscle tone, you're not. So, and that muscle tone is present in people who don't exercise, like children who don't go to the gym, but yet they're still vital and they're still healthy, right? That muscle tone is what's driving everything. So then the next question is, well, where does your body know how to produce 50 cycles per second from every motor neuron? Where is that coming from? And then you start thinking, well, where is that coming from? And then you find out that that muscle tone actually starts with the output of the muscle spindles. So the muscle spindles are producing an output, not at 50 times a second, it's somewhere between 5 and 20. But the muscle spindles are producing an output all of the time. And that's not dependent on anything else as well. That's spontaneous and continuous. And it alters depending on the tension and the stretch that the muscle is under, but it is always a baseline output from the muscle spindle. And so now you have this little battery, this little cell, this little cycle of input from the muscle spindle producing output from the motor neuron. And that's why I call my afferent input model the battery of the brain, because once that circuit is set up, it's also supplying ascending input into the central nervous system and brain. I mean, it's already hit the central nervous system, but then it goes up and informs the brain about what's happening with your body. But the basic circuit that's producing the input to your central nervous system is starting mostly in that muscle spindle.
Okay, I understand. And
Now, if anything happens to that output then, so that the motor output is deficient at all, then of course the muscle spindle isn't providing as much input, and that's where you get this muscle inhibition problem, which then results in inhibition from the spindles and inhibition of the output from the motor neuron. That's where you get muscle weakness that not just affects the muscle and the joint that it's controlling, but it also affects the afferent input to the rest of the entire nervous system. So in my view, everything that we do as chiropractors is and should be devoted to changing afferent input and making it more normal so that the output is normal. So we maintain normal muscle tone. And it turns out that normal muscle tone makes people strong and stronger. And when they're strong, they're healthy, because the stronger you are, the healthier you are. There you go. That's the basic outline of the afferent input paradigm.
sounds great to me and makes sense. Makes sense. So, in all honesty though, so would you say that a lot of people have that backwards? Because the way I kind of look at it, or I've been listening to people talk about this, is that they think that they seem to be of the opinion that the motor side is the dominant side, and therefore the actual afferent, so we're talking about efferent output, would be the dominant side and the primary, and the actual sensory feedback, the afferent input into your brain, would be almost negligibly important.
That's right. People seem to think that their brain controls their body. And while that's true to a degree, it's not totally true, because your brain doesn't have the instantaneous output ability. So if you have to jump off a 4-foot wall and land on your feet, you need your quadriceps to react instantaneously to that input. And your brain doesn't have that sort of speed of processing power. It has to come locally. It's like the general sending off his troops out into the field. And if he has to relay the message back from central headquarters all the time, it's going to take too long. What he must do is allow his units to operate independently. And so that's what this myotatic reflex does. It operates independently and then just provides feedback to the brain. In fact, it's driving the brain, because as far as I can see, there are no neurons within the brain or central nervous system that spontaneously produce output. That spontaneous production of neural messages has to start somewhere, and it starts mostly in the muscle spindles. Of course, the other senses provided as well, and something else that we get onto later, the periodontal ligaments also have muscle spindle receptors in them, or the same type of receptors. So a lot of that information is coming from your muscle spindle. So really in chiropractic, we have this above-down idea, and my paradigm reverses that totally. Everything is outside in and bottom up, really. So,
yeah, quite right.
Yeah.
Quite right. I mean, that's yeah, absolutely. And that's something I've also been struggling to change, perhaps, for the last little while. I started looking at people from bottom up. So literally start from the feet, work you up through the ankles, knees, hips, and so forth, and until you reach reach the very top. That would be my mechanical assessment of people as well. However, obviously, always in college, we were encouraged to look from top to the bottom.
Yeah.
And it was for a long time, I thought it doesn't make any sense. And my way kind of makes more sense purely because it's, more weight bearing. You go from the most weight bearing up to the least weight bearing. And hence, you go from the foundation of a building to the top of the building. And it kind of, I don't know, it just always made sense to me, but I was struggling to justify using a different method, should we call it?
Yeah. My priority is actually muscle spindles. So I want to test where there are the most muscle spindles. And so I'm going to test the largest muscles first, and then concentrate on spinal, because muscles have a lot of muscle spindles, especially in the neck. So for me, my favorite muscles are glutes probably, and spine, neck, and then of course I test everything every visit, but I'm concentrating on where are the most muscle spindles and where is the most muscle volume, because that's going to be the most critical for patient function. So the more muscle spindles that are inhibited, the weaker that patient is going to be.
Okay. So what do you reckon is the number one cause of muscle spindle inhibition then? What do you reckon is, if you can just point out one thing, or maybe two?
The withdrawal reflex.
Okay. Do you want to elaborate a little bit on that?
Yeah. So the withdrawal reflex, everybody knows the withdrawal reflex. It's that diagram you saw where somebody got a tack in their foot, and it caused facilitation of the hamstrings and inhibition.
Oh, yeah, I definitely remember that diagram.
Inhibition of the quadriceps, right? And then you think, oh, okay. So inhibition of the quadriceps. Okay, so are we going to test for inhibition of the quadriceps? And if we're not, so you will say, well, the person doesn't have a tack in their foot. Okay, so that's great. But it also happens with touching hot and cold. So you touch something hot and you pull away, right? That's the withdrawal reflex. And then you think, well, it also happens if somebody tickles me. So it's not just pain receptors, but if somebody tickles me and I flinch, that's the withdrawal reflex. And it happens all over my body. And it also happens in response to hot and cold. So you can touch something and you pull away, and it happens all over your body. So you think, okay, so they don't have a nail in their foot, but they do have a nail in their ear. And you think, well, hang on a minute, if they've got a nail through their ear, then surely if they've got a nail through their ear, they're going to put some muscles into facilitation, others into inhibition. And then they put another one in this ear and put some muscles into facilitation, others in inhibition. And suddenly they've got a dysfunctional neck, right? And inhibited neck muscles. Now those inhibited neck muscles then form muscular chains down the spine and maybe end up causing low back pain. Or they've got no, they don't cause pain in themselves, but they weaken the muscles that support the joints, and then the joints get injured, and then, so they can put earrings in 10 years ago, but now they have a car accident, and suddenly their neck doesn't heal because their neck muscles are inhibited and not able to stabilize the movement of those vertebrae. So the neck never recovers properly.
Or potentially the neck only got injured because those muscles were hindered in their action because of the earrings.
Yes, exactly. So at that moment of impact, let's say they had a car accident, at that moment of impact, there was the initial trauma where the myotatic reflex didn't work and stabilize the vertebra. But then for years afterwards, you need those muscles to work to hold those joints properly and to regulate the movement of everything that patient is doing. And without that subconscious regulation of movement, those joints are never going to heal properly. And that's why two people can be in the same car accident and one gets better in 2 weeks and the other one is still going after legal claims 3 years later.
Yeah. So would that be
in practice for a while, you start to see the patients who break every bone in their body and make a full recovery, and the other ones who bend down to pick up a bit of shopping and never get better. And you think it can't be the trauma that's the issue here. The issue is how strong is their body and how able is it to heal itself.
Okay. So what about in terms of old traumas? that potentially were not, I mean, I'm talking about mainly physical traumas, emotional, of course, has a different connotation, but
Sure.
maybe that's for a different day and a different debate. But if we're talking about simply physical traumas, twisted ankles, things like that, how do
Yes,
you find that
exactly.
those?
So any physical trauma should make a full recovery. If it doesn't, there's probably an inhibition that's not allowing that joint to recover properly. And
Yeah,
so whatever it is, I had a guy recently came in with a full boot on, the
like a surgical boot.
boots they have, yeah. And he had his third, he was a professional footballer, and he'd had his third stress fracture. They had
Wow.
diagnosed a third stress fracture. And although he had a boot on, he walked out of me after 30 minutes without the boot and with no pain at all.
Well, that's a bit of a result.
Just because I got rid of the inhibition in his arch muscles that was allowing this bone to be continually injured and not
Yeah.
heal properly. And,
Okay.
and this is a guy with the access to the best physios in the country, but nobody had been able to help him, and he was off, he couldn't play. And this was the third injury in 18 months. So, but he didn't need the boot. He just needed his muscles to support him. That's what
That's right.
muscles do. They support you, and they limit motion, and they are our stopping force. They are a brake. They are also a motive force.
Accelerate as well as produce power. Yeah.
Exactly.
No,
So
absolutely.
they need those to stabilize us so that we don't get injured.
Oh, absolutely. So, for example, I mean, this is a scenario that I do personally see a lot in clinic as well, which is people who come in with your run-of-the-mill low back injury, with a bit of sciatica thrown in the mix, and they get very confused when I say that. Look, actually, the problem most likely is coming from your ankle and your foot. And there's that element of, okay, how do you communicate this to the patient without coming across completely loopy? However, I know in myself that is the case. I know how to make sure that ankle works better and what rehab they need to do. And then they think that it's a miracle that their back got better.
Well, yeah. So that's where a good muscle testing. So the thing that I do is good muscle testing, and I know muscle testing is viewed with a great deal of skepticism in many circles, but it's because
That's
it's
right.
not being done properly. Okay, and people don't understand that what they must test is this myotatic reflex. And the myotatic reflex is the knee-jerk reflex. It's what protects your joints from a sudden input. So if you jump off a chair or something and you land, the myotatic reflex is what makes your quadriceps and every other muscle in your body resist the incoming force so that you don't fall on your face. It happens every time you walk down a stair. Every movement, you're using the myotatic reflex. And isn't it ridiculous that we only check the knee-jerk reflex and we don't check it virtually anything else, like any other muscle? But every muscle is working with the myotatic reflex every time you move. And so it's important then to imagine how the myotatic reflex works. And I find it best to imagine if somebody threw you against a wall, Mika, if they threw you against that wall behind you, what would you do just before the impact? What would you do to protect yourself from the impact?
Brace.
You would activate the muscles that would take the force, wouldn't you? And so when you activate those muscles, like against the wall, those they're going to then absorb the force of the wall, and then you push yourself away. That's what happens when you walk down a stair. And so the important way to test a muscle is not to push into the muscle. Don't do the brake test. The important thing is to hold the limb where it is and have the patient push into you and match their force. That's the important part of muscle testing. And force them to push you away so you can feel for the contraction of that muscle through its range of motion. So you must test for strength, and you must test for an adequate input of that muscle. That muscle must engage and push you away.
Okay.
That's the really important part. Now, if your patient with the low back pain came in and then you could identify the weakness in their back, and then you could say, well, look, if I put your ankle or knee in this position, your weakness goes away. Then your patient would have a way of figuring out that their foot was related to their back. What I do though is if they're coming with low back pain and I sit them down, I say, can I have your foot for a minute? And I just test their foot, right? So I have a way of finding disc lesions with weakness in the foot. So there are nerve roots that correspond to different muscles in the foot. So the further distal you get, the more distinct the nerve supply to those muscles are. So for instance, the peroneus longus is a fairly direct connection with the S1 nerve root, L5-S1 disc. And so when you test that properly, let's say it fails on a patient, you could say to the patient, why do you think I'm testing the muscles in your feet?
Quite.
The patient says, I don't know. You say, well, you got a problem in your back and the nerves from your back drive the muscles in your feet and this one's not working properly. This tells me exactly where the problem is in your back. And see, from them, they know that even though you're working on their feet, you're actually dealing with their problem that they came in with.
No, quite
and
right.
Then the other good thing is they don't ask you any more questions.
Well, makes it easier for you and me then in the end, doesn't it?
Exactly.
No, quite right.
Me. That's all it's about, right?
No, absolutely. Now, do you know, if we come back to one thing actually you mentioned earlier, which was the procedure of testing muscles, and essentially, like you said, you've got muscle tests for strength. Now, I have attended a muscle testing workshop or two, and where they were saying how you're looking for the first bite, if you like, on a muscle test. You're not looking to overpower the patient. So what's your kind of take on that? Is it that you are looking to actually challenge the patient's strength, or is it more like that?
What you're doing is you must engage the myotator reflex to that patient's capacity. Now, how you do that is you ask the patient, you put the patient into your starting position, wherever that is, and you ask the patient to pull again in a certain direction. So you tell them pull up, and then you resist whatever comes at you. You just hold them firm. You don't push them down, you just hold them firm. And what you're feeling for is that muscle going to keep getting stronger for at least 2 seconds? Will it push you away? And that's what you want to look for. Now, anybody that comes along and does light testing, they try to overpower and surprise the muscle. That's not good muscle testing. A good muscle test, to test for strength and to test the myotator reflex, they must push you away. Okay, so you start and you just hold and you ask them to push through a range of motion. And it's very important also that that you test the muscle in its different range of motion. So you can test a muscle that's fully elongated and fully shortened. And a strong muscle should be strong throughout the entire range of motion.
Okay, that sounds quite involved, doesn't it?
It's not that involved.
Time consuming, perhaps.
Well, it shouldn't take more than 2 or 3 minutes to scan every muscle in the body, really.
Wow, that's pretty fast.
Yeah, you don't mess around, but of course that takes a lot of training, a lot of practice. But
yeah, exactly. No, you got to have it down to a T. If you can speed through it at that speed. Goodness me. I would probably be stuck thinking about muscle names for the first minute and a half, anyways.
Well, see, you got to stop that too, because muscle. In AK, what they did was you had to test every muscle, right? And Kendall, the original book that AK came from, AK muscle testing came from, they were concerned to isolate each muscle. But we never work like that. Bodies don't work one muscle at a time. We work with groups of muscles, and we work with synergist and antagonist and agonist, and we work with whole body coordination. So you can't isolate each muscle, and that's what makes the way I test muscles much easier, because I only ever think in terms of movement.
Yes.
Only testing movements. It doesn't matter that this is deltoid. It matters it's abduction, right?
Yes.
So I simplify it as much as I can, because learning all the muscles, origin, insertion, it's sort of useful, but not really. Really you want, how is this person, what movements are not working with this person? What can't they do? In fact, that's one of the things I say is, what can't you do? So show me what you can't do, and I'll figure out why you can't do it. One of
Yeah,
my
precisely.
patients is, he was going for the world record in World's Strongest Man competitions in his weight class. And
Yeah.
one of the things they have to do is a log lift. So a log lift is not like an Olympic press with a bar. A log lift is out in front of your body. You can't get it close to your body. And he was getting stuck at sort of 90 degrees of flexion, and he couldn't push above his head. And so we had to work out where was the weakness. And of course, there's lots of things here. There's all of the anterior deltoids and triceps and elbow and wrist, and you have to trace it all back. And turned out it was the angle of his head, of course, as the bar came back. And so you had to work through every one of those. And sometimes it's the abductors and adductors, and work through all of the muscles that would be involved in that motion, so that finally he can power up through that sticky point he had. Right?
Absolutely.
He had a sticky point.
And that I think is, is key when it comes to also all the sports chiropractic stuff. When you're looking at patients, oftentimes elite level, where they have a very specific problem. So you kind of have to put them into that position, and you have to understand, and so you can actually see what they're doing, what is causing the problem. That's something that you can't really describe.
No, and it's really, but once you've got all of their basics out of the way, once you've got them mostly strong, that's a really good way of doing it, and putting them into the position of failure. And of course, sometimes it's tricky, because sometimes you're not there to see what they're actually doing. I remember I had a woman power lifter, and I got it totally right, and I was convinced she'd be fine. But she came back from a competition, she'd hurt her back again.
Oh no.
And that happened, and she did that twice to me. And I said, this is ridiculous. I'm coming to your competition. So I turned up at her next competition, and she was getting ready to do the lift, and she was storming up and down and storming backwards and forwards and addressing the bar. And just before she was about to lift, she stormed over to her coach, who waved smelling salts under her nose. And she went, and she came up and she lifted, and she hurt her back.
Oh no.
Because the sensory input from the allergy to whatever was in the smelling salts made her totally weak, right? That the smelling salts, she was allergic or reactive or intolerant to some chemical in that smelling salt. That was what destroyed her.
No,
and
there you go.
You can't know that stuff unless you're there, right? Unless you see
No, well, exactly. I mean, that kind of reminds me of a case. I had a very amateur cyclist, but a very top end amateur cyclist. And this chap, he had this irritating recurring low back and hip problem. And he would feel brilliant leaving the clinic. And only then a couple of weeks down the line, he'd give me a call, say, oh, it's happened again. And we were bashing our heads against the wall trying to figure out what was going on, because the muscle didn't seem too bad. He had a bit of tightness here and there and whatnot. And then in the end, I said, look, okay, so let me see your training bike. He said, oh, it's on the turbo at home. So it's on the turbo trainer, a stationary trainer in his house, because that's where he does most of his meaningful training. So I said, right, I'm coming to your house tomorrow. Where do you live? Oh, I got your address on the clinic forms anyway. So I'll pop over tomorrow after clinic and I'll come and see what your setup looks like. So I rocked up, and the chap shows me to his pain cave, as they call them, cyclists. They have those kind of names for their little training rooms. And there's this bike on a turbo trainer. And as soon as I saw it, I started laughing. And he was a little bit offended maybe at first. And I had to qualify myself. I said, look, man, I know exactly what the problem is. I know exactly what's happening here. So it turns out his saddle was completely collapsed on one side. And he had actually chipped the paint off the frame on one side because his knee kept brushing it. And I mean, come on, man, that's almost so basic.
Yeah, so basic. How on earth could that happen? Yeah, how would he put up with that? I mean,
you never
you
know.
asked me before, what's the biggest cause of low muscle tone? And I guess what I'm most known for is foreign bodies. So it's not an immigration policy. It's just that we do stuff to our body, like the earrings. Okay, metal is the biggest irritant of the withdrawal reflex, and when you have the withdrawal reflex, you have to have muscle inhibition and muscle facilitation. And so when you've got that, you've got muscle imbalance, And one of the biggest things is look for foreign bodies. Now, I suspect that the elite sports people might not have them, but they do. You know, if you just watch any Olympic Games and watch the athletes that break down, and they're virtually always wearing earrings or neck chains. Those are the big nasties, earrings and neck chains.
All right. So how come the neck chain is so much? I mean, that's not piercing anything. That's not necessarily, well, I'm assuming because you're phrasing it that way, that it is a major irritant and it's causing an irritation and a change. But
you have to remember how sensitive your skin is. Your skin is so sensitive, it can feel one hair move. All right. Now you can if you have a pebble in your shoe, you have a tiny pebble, a tiny stone, how long are you going to leave it in your shoe?
Not for long.
No, unless you're desperate, unless it's an emergency, you're going to stop and take it out. Okay.
That's right.
So your body doesn't tolerate irritation at all. It doesn't tolerate it. Now, you have a chain link chain, you put it around your neck. Which bits of your skin are being irritated?
Anywhere it touches.
Well, yeah, the back of your neck. Now, if the back of your neck is irritated, the withdrawal reflex says you're going to go into flexion. You're going to go forward. So your flexors are facilitated. Your spinal extensors are going to be inhibited.
Okay, gotcha. So would that apply more or less to all bits of metal? You know, even in, like, for example, if somebody uses an old-fashioned tattoo paint that may have metal oxide in it or something like that.
So we're talking about physical metals, not metal salts. Okay. So
right. Okay.
Only physical metal. So I had a guy with a typical, I mean, the most dramatic one was a guy with a typical low back disc, antalgic, positive minus sign, holding on to his thighs in agony. And I just lay him down, did a few things, and he got up and he said, "That's amazing. I can't believe that's really great." And I said, "Come here." And I picked up his gold chain and I just laid it around his neck, and his knees buckled. They just buckled. He went straight back down to holding onto his thighs. And he came back a week later and he said, "You know, I had my low back pain for about 9 months since my birthday. My wife bought me the chain. And it went away for 2 weeks when I was in Greece because I didn't take the chain. And it's been back ever since because I wore the chain." So he then had done his own clinical trial of this gold chain. So it's not the weight of the chain, it's how much it irritates your skin. So it's the irritation that really causes the problems.
Quite right. No, I remember, you know, that like I mentioned earlier, that first lecture that I saw you deliver, a workshop at the college, and I remember you pulled up a friend of mine from the audience. We'll leave him anonymous as well, but a bigger chap, and he had ongoing low back issue, and I mean, this obviously proved to us that it was genuine because we knew he had a low back issue. He never would shut up about it. Yeah. And so essentially, you stepped down to the front of the class and you just did a few bits and bobs. I can't remember exactly what you did, but it seemed almost irrelevant, if you pardon the expression. But I didn't honestly understand what he was doing. And then finally, just looked in his mouth, and I said, "So, you know, that feeling at the back, when did you have that done?" And turns out it was relatively short time prior to his low back becoming painful. And you put some like a dentist, you know, the little foam bit between his teeth, yeah. And he did this thing and bent down, touched his toes, came back up, and his face was. I have never seen anyone more surprised than him at that point in time. But it got better because he actually took the thingy out and his pain came back immediately.
Yeah. Isn't that amazing? You can do your own clinical trial 100 times if you want, and the patient is their own control. Now, if you want a control group, which would you rather have? Would you rather have 100 other people, or would you rather have that guy, you know, doing his own control? Because when it's your own control, you know it's going to work, at least for that person, right? It might not work for anyone else. But in a clinical situation, what matters is that it works for that person. So
That's
one
right.
of my big beefs with clinical trials is that they work by averages. You're taking the average of one group and comparing it with the average of another group, and the outcome that you get from the averages doesn't apply to any individual.
No, well, that's
Whereas
true.
if you can do your own clinical trial with the one individual, they are their own control. You're doing a trial as many times as you want to do it, 20, 30, 40 times, and then you've got an almost guaranteed result then when you eventually work it out, like, because
Well,
you
I
can.
think that just produces the most clinically relevant data, the
Of
most
course it does.
clinically applicable data, perhaps. No,
Absolutely. Of
I
course
mean, now
it's
listen,
clinically applicable.
listen, I understand the whole point of doing clinical research and that and it's good as a guideline. It's good as a, like to teach students, okay, this is what happens most of the time, right?
Yeah.
However,
That
of
doesn't
course,
help
then
you in
you have to
clinic.
figure out, okay, well, how is this person most of the time? Is this person something different?
Yeah, exactly. Yeah.
Which usually it is something different, but at least it gives you a starting point, doesn't it?
Yeah, it does. Yeah. Yeah, so one of the other places people have foreign bodies that nobody looks for is in their teeth. And turns out the teeth are so very important in neural messaging and provide a great deal of input into the brain. And so you have to be careful not to mess up the incoming messages from your teeth.
Mm.
And one of the ways that people do that is put metal in your mouth.
Yep.
It's a tragedy. It's an awful tragedy when that happens. And nobody will ever find it because doctors never look in your mouth and dentists never look at your low back or your hips.
Yeah, true. No, well, that's the problem with being very specialized, isn't it?
Yeah.
Knowing hell of a lot about very little, if you like.
Yeah.
Now, you know what? I don't know if you ever come across this kind of thing. It's slightly different, but I thought you might be interested. But there's this thing that came out a while ago where they were highlighted there were some brain cells in the heart, the little brain of the heart. They talked about that. It's the Heart Math Institute in the States that they do this kind of stuff where they look at the signaling from the heart to the brain.
Right.
And so I found it very interesting. This is maybe goes a bit off the left field on that, but I found it interesting, and
Okay.
hence what's the application? Okay, not sure if there's an application when it comes to sports chiropractic specifically, but it's potentially more to do with sort of mental emotional game and that kind of thing. So hypothetically, if somebody puts a foreign object into the heart or aorta or one of the coronary arteries, would that then have a disruptive effect on the heart function and how that heart communicates with the brain?
Oh, well, all of that's a bit wishy-washy for me. So all of my stuff is based on sensory input. So if you have a foreign body like a hip replacement, that doesn't provide too much bad proprioceptive information because the screws and the metal are inside the bone marrow, and the bone marrow has no sensory nerves. And so
Okay.
you can do whatever you like, and it doesn't cause pain, and it doesn't cause sensory irritation. Just like foreign bodies within your liver or your brain, they're not going to cause too much sensory input. Now, the problem when you talk about hearts is, of course, you can take a heart out of the body and it still beats. There's not a direct connection, certainly not neurologically and certainly not musculoskeletally, between what your heart's doing and what your body's doing. And we know that because you can do all sorts of physical function no matter what your heart rate is. So I'm not sure that heart rate is where you should be, and certainly the heart-brain connection maybe not so much. Although in AK, Good Heart did come out with really weird stuff about what to do with the heart to influence brain function, but I left that behind a long time ago.
No, fair enough. No, these are the kind of things that sometimes when we are stuck at home and have nothing else to do,
Like now.
you start picking up things to read and looking into things that you otherwise might not have time for anyways.
Sure. All right.
No, absolutely. Now, what I was going to ask you about a bit more about sports chiropractic, coming back to that.
Sure.
do you have any little clinical pearls you want to share?
With sports,
Yeah.
I think I would just encourage anybody who wants to do sports medicine, they have to get really good at muscle testing. They have to get really, really, really good at muscle testing throughout a range of motion. Okay, so test with the muscle fully elongated, so the joint fully stretched, and test with it fully contracted. And then variations of that. Like one of the interesting things I've found fairly recently was to do with cramping. You know, cramping
Okay.
is a great bugbear for a lot of practitioners, isn't it?
Yeah, absolutely.
You really don't know what to do about it. Turns out cramping is a sign of hypertonicity. It's just as I talked about inhibition from the motor neuron.
Yep.
Cramping is too much output from the motor neuron. And if you've got too much output, if you've got too much output from motor neuron, what you should have is inhibition of the antagonist. With the law of reciprocal inhibition, if you've got one muscle that's too tight, its antagonist should be inhibited. Would you agree?
Yep, makes sense.
Yeah. Now, the trouble is when let's say somebody's got a cramp in their calf, you try to test the antagonist, which would be the dorsiflexors, and there's no weakness. So how can that be? How can there be no weakness when the theory says it must be weak? Well, the thing is, you're testing it wrong. And if you've got a cramping calf, it is weak in the dorsiflexors, but you've got to test them at the end of their range of motion. So you've got to put the patient full plantar flexion and feel for their ability to dorsiflex from full plantar flexion to pull back that way. That's when you'll feel the weakness. That's when you'll get the weakness.
So you don't test it in neutral, basically.
Don't test in neutral, and certainly don't test it in full contraction. You just won't find anything.
Yeah.
Test it from full elongation. Now, if you can do that, then the treatment, of course, is to strengthen the dorsiflexors, and then you'll calm down the overactive calf muscles.
Yeah. No, it makes perfect sense. So hence, it's almost like that. It's almost like comes back to the cyclist guy I saw. You know, it's quite simple. You know, when you think about it.
Well, it took me forever to work it out, and I don't think that's intuitive. You know, people don't think that way. That, well, it's cramping; it must be overly tight. Therefore, the antagonist must be inhibited. Why can't I find it? But when your whole life is devoted to muscle tone, you know, you do start to think in those sort of terms, and that's when I forced myself to work it out, and eventually found it.
Yeah, absolutely. Now I was reading another book more about movement, and it wasn't essentially about neurology. It was more all about movement and mechanics more. But in this book, they were talking about, you know, how do you find center? How do you find the sort of the happy middle ground, if you like, for the human body, and essentially should you? Because of course human bodies are designed to be unstable. We oscillate in all the time in terms of movement. There is never really that complete stillness in the body, and hence, therefore, seeking to really stabilize a body would be very compromising for the end range.
So yeah, but the important thing about whatever you're dealing with is normal muscle tone. So the stronger, we know from at least 60 studies now, that the stronger you are, the longer you live and the less disease you suffer. And so the more you, like, that's where I love sports chiropractic as well. That's because you're trying to make people stronger. And people talk about muscle balance. It's not about muscle balance. You have to eliminate every weakness and make people as strong as they can be, because stronger is always better no matter what condition you're treating. And so if you can devote yourself to creating strength in people, then you're doing them a great service and you're actually improving their health.
So I feel that there's a little definition is in order. So I'm thinking your definition of strength doesn't mean Arnold Schwarzenegger type of strength necessarily.
No, it's not the strength you build in a gym.
Yes.
It's your innate strength.
It's your ability to harness your full potential, is it?
Yes. It's your neurological potential, yes. Now, the trouble is if you don't have that and you try to go to build muscle in a gym, you'll end up hurting yourself. You have to be strong to exercise.
That's
you don't
right.
get, you do get strong from exercise, but only if you're strong to start with. So you can't strengthen an inhibited muscle with exercise. It's like trying to say, all right, you've got an attack in your foot, let's go and do some exercise for your quads. Those quads are not going to strengthen until you take the attack out of the foot.
Yeah, exactly.
Wasting your time with the exercise if there's still inhibition present. That's why I don't understand trainers and practitioners who try to give exercises before they've looked at what's actually weak. You know, have they actually tested what is weak? And therefore, even if you think exercises are appropriate, which usually they're not, but even if you think they are, have you made sure that that patient is fully able to exercise, like fully not inhibited at all? Yeah,
that's right. No, absolutely, and that's something that, of course, I see in clinic equally a lot. You know, patients come in from all walks of life, and they always keep blowing up like you're a weightlifter person, you know, and there's always there's something that has been missed, and that is still causing that patient to be inhibited, essentially. No, it makes perfect sense. Absolutely. Good. Hey, you know what? I reckon we'll start wrapping up here. Sure. We're starting to get to near our mark of allocated time. I think there's another person who wants to use our Zoom. So what we'll do is we'll just thank you very much, Simon, for this evening's chat. I've really enjoyed it. It's been very educational, and we'll finish off with a little message from our sponsors.
Okay, can I just say that if people want more information, my website is afferentinput.org. Okay,
that's great.
It's afferentinput.org.
Absolutely, and so that's basically where I was going to go next. So obviously, FICS is looking to put on a lot of new material on the website, you know, in the portal, and we have a running promotion for the head injury module to upgrade your ICCSB to ICSC. So that means you can then come and volunteer on the games and work with the top class sports cars in the world, and of course learn around the subject. So check out Simon's website, afferentinput.org, was it?
.org, yeah.
.org, and have a look at that. There is loads of cool material there. Equally, check out all this other stuff. Now there's people are pumping good content onto the www stuff. So hence, please educate yourselves, chiropractors. Make sure you have lots of good questions to ask and hit the ground running when it's time to open the clinic doors again. So we'll call it a night here, Simon. Thank you very much for joining.
Thank you.
And being part of the World Sports Chiropractic Chat Show.
Thank you very much for the work you're doing. It's good to see you.
That's great stuff. So what we'll do is I'll stop there, and we'll see you next time.
Thank you.